Good morning. I'm here today to talk to you really about the progress, or maybe more appropriately, the lack of progress in development of chemotherapy treatments for hepatocellular carcinoma. Hopefully some of the very promising basic science work that you've seen today and yesterday will lead to some more effective treatments. Financial disclosures, I do a lot of clinical trials, and I do have a lot of financial support from multiple pharmaceutical companies. So hepatocellular carcinoma is the 5th most common malignancy in the world. The issue is that it's endemic in Africa and Asia, particularly places with high incidence of hepatitis B, and the annual incidence has doubled in the past 30 years within the United States due to the emergence of hepatitis C infections. Unfortunately, this is really a somewhat unusual global distribution. If we look here, we can see that really the major parts are Asia, sub-Saharan Africa, places like Australia and North America have rising incidence, but lower incidence secondary to the immigrant population. So again, it's really a major Asian and African disease currently. In terms of the treatment of liver tumors, we have surgical resection. I'm a surgeon, so we in some cases can do liver resections, partial liver resections, but the main case of really the best treatment overall, but very limited because of the number of patients who can undergo that, is a liver transplantation, and there are specific criteria that are adhered to prevent recurrence. Unfortunately, most of the cases that we have are really palliative forms of treatment, radiofrequency ablation, where we use electrical energy to ablate tumors, microwave, where we use microwave energy to ablate tumors, transarterial chemoembolization or drug-eluting beads, where we inject chemotherapy directly into the liver, radiomicrospheres such as Surtex or Therasphere, where radioactive particles are injected directly into the liver, and then really systemic chemotherapy. Unfortunately, in the current time, there's only one drug that has been proven in randomized prospective trials to be effective as a systemic chemotherapy agent, and that's Sorafenib or Nexavar. And surprisingly and unfortunately, this has been around now for about 8 years, and we have not had any other significant breakthroughs. There have been multiple drugs that have unfortunately come to clinical trial and failed, largely because I think the area of hepatocellular carcinoma, we're just not very sophisticated in drug design, and hopefully some of the more future studies that are ongoing will be more promising. In terms of how we treat liver cancer overall, there's really an algorithm known as the Barcelona Liver Clinic Staging and Treatment Criteria, where basically patients who have early cancers undergo resection, moderate cancers undergo liver transplant, and then this whole area of palliative treatments, which is a combination of chemoembolization and systemic chemotherapy, such as, again, Sorafenib. So we all are familiar with this in terms of there's a combination of factors that undergo in tumor replication. Early on, 10, 15 years ago, there was a lot of interest and thought that we'd all figured everything out because it was really a question of vascular endothelial and angiogenesis switch, and that if we could therefore block this with drugs such as Avastin, we would block tumor replication. Unfortunately, these drugs such as Avastin have been highly successful in the treatment of things such as colon cancer. They've been, unfortunately, relatively ineffectual in the treatment of hepatocellular carcinoma. As we become a little bit more sophisticated, we've really learned about that there are indeed multiple targeting mechanisms, and Sorafenib, the drug that I'm going to talk about today, is both the vascular endothelial growth factor receptor, but probably more importantly, it's now becoming increasingly clear that its role in the inhibition of RAF kinase is probably where its major chemostatic effort really is. So again, we have this angiogenesis going on. We also have basically this ability to block both angiogenesis and this pathway leading to cell replication, and also a pathway leading to apoptosis, which makes Sorafenib a very ideal candidate. In fact, again, the only candidate that's available for the treatment of HCC. So again, it's the only drug that's been approved and shown to prolong survival in unresectable hepatocellular carcinoma. Interestingly, as an oral agent, many of these drugs have now become the one-size-fits-all phenomenon. So the drug is dosed as 400 milligrams BID, regardless of body surface area, gender, or sizes, and that's really very different than most chemotherapies, since most chemotherapies tend to be dosed based on other factors such as body surface area. So initially, as with everything, there was a phase 2 study that was designed that looked at hepatocellular carcinoma and the treatment with 400 milligrams of sorafenib BID. This was given until disease progression or drug-related toxicity. 137 patients in the early studies, and a median survival of 9.2 months on patients with drug. So this then led to a randomized prospective phase 3 study, which was known as the SHARP study. It's a multi-center study. It was done mainly in Europe because it required a histologically proven hepatocellular carcinoma, so it required a biopsy, which at that time was really not considered standard of care in Asia or the United States. It was double-blind, placebo-controlled, one-to-one randomization, and this ran from March of 2005 to April of 2006. So again, it was stratified on ECOG, geographical region, macrovascular invasion, and again, it was one-size-fits-all, 400 milligrams BID versus placebo, and the drug was discontinued when there was a radiologic progression or worsening of symptoms or drug intolerance. If we look at the patient characteristics that were in this study, they were very different than what one would see in a predominant Asian population. There was really a very low number of percentage of patients who had viral hepatitis. This would be much higher in an Asian population. And again, this was mainly a European-based trial because of the criteria that were involved. Most of the individuals, over 3/4 of them were male. If we look at the outcome, the study was stopped by the Drug Safety Monitoring Board because of the efficacy. Sorafenib had an average increase in survival to 10.7 months, and the placebo-controlled arm had an average survival of about 8 months. So it was highly statistically significant with an increase in survival by roughly 2.8 to 3 months, but arguably this was statistically significant but potentially clinically irrelevant in the sense that you've increased survival, but you've increased it with a significant toxicity profile. If we look at the radiographic time to progression, there was basically one doubling time improvement between the placebo group and the treatment group. It went from 2.8 months to 5.5 months, so basically about 100 days or one doubling time for hepatocellular carcinoma. In terms of the ability to decrease tumor size, there was a small number of patients in placebo who had decrease in tumor size and a greater number of patients who had a decrease in tumor size from the patients that were on Nexavar. However, one of the problems with this is when we did this study, we used what was known as standard RECIST criteria, which measured just specific tumor size. And if you know hepatocellular carcinoma, this was clearly an error in how we were monitoring them, because hepatocellular carcinoma is an arterial enhancing lesion. When it dies, you get necrosis, and the tumor actually swells. So when you see in this patient, you have a large hepatocellular carcinoma. This is arterial enhancing with small amount of necrosis. This was treated with drug. These darker areas are areas of necrosis, and at 4 months there's significant necrosis here. However, as you can see, at 1 month, this patient, if it had been on trial, would have been removed from trial because they'd actually had an increase in tumor size. So one of the results of this study was we've now developed what's called modified RECIST or modified WHO criteria, which now take into account tumor necrosis when we clinically follow cancer patients with liver cancer. Side effects were quite high in this particular study. The highest side effect was either significant diarrhea or a hand-foot syndrome, where there's desquamation of the skin from the hands and feet, and leading to discontinuation or decreasing in drug in a significant number of patients. And again, this is what one sees in hand-foot syndrome. You see these significant developed erythema and basically calluses and ultimately ulcerations. Based on this study, the drug was approved in the United States and in Europe for treatment of HCC. A subsequent study was then done in the Asian population, where it was a 2-to-1 randomization. Again, it was a one-size-fits-all of 400 milligrams BID. 2/3 of the patients received sorafenib, 1/3 of the patients received placebo. Interestingly, in this study, the survival was statistically significant, but the patients with drug only survived 6.5 weeks. So in fact, the patients who had drug in this study actually lived a shorter period of time than patients who received placebo in the European study. So again, there's clearly a difference in disease between the Asian population and the non-Asian population. Again, statistically improved survival, but again, very, very modest, if not clinically insignificant improvement. And again, time to progression, basically a 1.5-month improvement in time of progression. So based on this, we did start giving this drug to our patients, but we noted something very significant. Most of our patients that we treat in Southern California are of Asian immigrant descent, and so we presented this initially about 5 years ago at ASCO, and we noticed that among our Asian population, most of these patients, in fact 97% of Asian patients, could not tolerate 400 milligrams BID. And the reason for that was they had a statistically significant lower body surface area than the average Caucasian patient that we treat. So this really begged the question then, is if you're giving a drug at lower than the recommended FDA guidelines, are you actually getting therapeutic treatment of drug, or are you just basically wasting your time? So what we decided to do was a pilot study looking at pharmacokinetics. And interestingly, again, this is a drug that's been introduced, has worldwide use, and has absolutely only virtually no pharmacokinetic data available on this particular drug. And so we were able to go forward, get funding from the company to look at a pilot study of metabolism between Asian Americans and non-Asian Americans. So again, sorafenib, this is the drug itself. It's highly water insoluble. It is an oral agent, and that is the main component. And then again, through N-oxidation, the M2 metabolite is about 16%. So over 90-some% of the drug exists as either the parent compound or N-oxidation metabolite in the system. So what we did is we looked at a combination of patients who were either Asian or non-Asian, did a 12-hour pharmacokinetic study, and looked at this based on whether they were on high dose, low dose, and whether they had a high body surface area versus low body surface area, and whether they were Asian versus non-Asian. So again, 27 patients, ultimately small study, 13 non-Asians, 10 Asians Americans. Again, only one of the Asian Americans was able to tolerate a high dose, and in fact that was a 35-year-old gentleman who was about 6'4" and 260 pounds, so typically not your average Asian body surface. Most of the patients that we had in the Asian population were typically 4'8", 5'3", 120 pounds. So again, if we looked at the area, this is an ongoing study, but the patients who we've had on high dose have actually done very, very well, and they're all alive at several years out. At the lower dose, we've had 2 mortalities, one at 2 years and one at 283 days. So again, much longer survival than had been suggested in the SHARP study. We also had one patient in the low dose who achieved a complete response at 200 days of therapy, and this patient's still alive 3 years out. If we look at the, again, the body surface area, much lower body surface area in the patients who were Asian Americans. The median dose tolerated was much lower in the patients who were on sorafenib and Asian American. The area under the curve was somewhat different, but not statistically significantly different, as was the M2 metabolite. If we look at this in a graphical format, we can see then again, over a 12-hour period, patients on high-dose sorafenib certainly had higher levels, but again, the variance is such that there was not a statistically significant difference between high dose and low dose. Again, if we look at low versus higher body surface area, the differences become even less significant when you account for body surface area. If we look at Asians versus non-Asians, again, it really basically shows no difference between them. And interestingly, it seems to be, again, maybe a statistical aberration, but that they actually have higher levels of the metabolite and the primary product at the end of the 12 hours. So perhaps they have a slower metabolic rate. So again, if we look at mean differences, there was certainly a trend toward, there were higher levels in the high dose versus low dose, but again, because of the overlap, there was no statistical difference between patients on high dose or low dose, and no statistical differences between that which you accounted for body surface area. So here's the patient who we had who had a complete response. This is a gentleman who had a massive right lobe hepatocellular carcinoma with hepatitis B. He was started on 200 milligrams of sorafenib BID. He could not tolerate the high dose. Again, by MRI, you see a very large right lobe lesion, which basically over a period of 9 months began to significantly shrink. At the end of 1 year, this is what we had radiologically, and took him to the operating room and completely biopsied this lesion and excised it, and he had basically 100% necrosis in that lesion. So he had a radiologic complete response, and basically, again, his levels were such that they really fell on the lower end of what we saw in the general population, but obviously, arguably, he had significantly high enough levels to elicit a complete clinical response. So obviously limitations, very small sample size. Patients had to be on drug for a minimum of 2 to 3 months to be in steady state level. And again, it was very difficult to find patients in our population who were on stable high doses for an extended period of time. But the analysis revealed a trend towards comparable levels of both populations. It suggests that maybe studies need to be done at a more at larger scale to see whether lower dosing of this drug may be effective and might be a better allow for better long-term use of this drug and more efficacy of this particular drug. So again, large population-based studies are needed to validate these findings. I'll stop there, and I think I'm the only thing holding us between now and a coffee break. So thank you for your attention.
So any questions from audience?
Yes.
So, in between different stages of cancer, during surgical resection, do you see any difference in the cut margins?
I'm sorry, can you say again?
Do you see any difference in the cut margins of different stages of cancer?
In the differences in the margins, I'm sorry.
Cut margins. Surgical cut margins.
Surgical cut margin. Yeah, there's really not enough data on that, for this, because most of these patients, again, are patients who are not surgical candidates due to size, location, numbers. So very few of them ultimately ever go to surgery. So we have very, very little of that. And in fact, one of the, I think, shortcomings of the original studies is no biopsies were done of these when the patients were on, once they received treatment. So we don't even know if the drug is actually truly getting into the majority of these cancers and being effective. So, I think at the HCC level, we're very much neophytes when it comes to doing clinical studies, and I think we probably learned from the more successful clinical studies, as to how one would look at that. But it's a great question, but it just wasn't done. It wasn't designed to that study.
Any more questions?
And
Yes.
Yes.
so do you think that any other parameters should be considered along the BID?
Well, again, it really doesn't make a lot of sense as to how they dose this. If you look at pharmacokinetics, the decreases from 400 milligrams BID to 400 milligrams a day to 200 milligrams every other day. So it makes no sense based on the pharmacokinetics how you would drug decrease dosing. And again, off-label, one would suggest that you probably should drug escalate and start at 200 milligrams a day and go upwards and try to get the best tolerable dose for the longest period of time. And that's really what's being suggested in the post-marketing studies that are out there. But it's difficult because the company can't speak to anything other than what's the FDA-approved amount, which is the 400 BID, which really was a dose that was really just basically drawn out of the air from healthy volunteers. And it's surprising because there's virtually no pharmacokinetic data available on this drug at all. Yes?
Out of 400 milligrams, how much reaches actually to the tumor? Is there any bioavailability?
Yeah, again, no, they didn't do that in the study. It would have made a lot of sense to biopsy the tumors. If you already were going to require a biopsy to get in, it would have made a lot of sense to biopsy the tumors after you treated them.
Yes.
Or what we've done in a very small study, but those results are still not ready, or they're not mature yet. So we've been putting patients on drug before we take them to surgery, and then doing and looking at the explant as well as the contralateral lobe to see if you're actually getting drug into the tumor.
Yeah, that's the important
Right,
thing.
exactly.
So that could be the reason of some of the failures in the.
Right, it may just be a particular.
It's a bioavailability.
Bioavailability and tumor uptake, absolutely.
Yeah, tumor uptake, yeah, the cells.
Okay. And one of the limitations is that you mentioned about that most patients cannot tolerate the high dose.
Right.
So is any reason you use low dose and high dose? Have you ever tried so-called intermediate dosage?
Well, what we do is we try to escalate upwards. We basically defined, for the purpose of the study, of anything less than 600 milligrams a day we called low dose, and then intermediate to high dose was 600 or 800.
Okay. And also the other limitation is the sample size. You mentioned about only about 23 patients being recruited. So have you any idea or any data in Asian country in which they can have a similar study using a larger population of patients?
I think it's possible. Part of the problem is to do this study, you require the patient to be there for 18 hours getting blood drawn. So it's a little difficult to convince them that they want to spend a day for basically just for science.
Okay.